In today's episode, we are going over a case study of a weightlifter who gets good old cervical radiculopathy. Let's do this. So, what was the subjective examination for this patient with cervical radiculopathy? 1 week prior to coming into physical therapy with me, she had some extreme pain radiating down her arm and some into the neck. And she doesn't really recall a specific event that had led to this. She did remember dropping a barbell on her neck. It was about 2 or 3 days before the onset of pain. So she was doing power snatches and she tried to bail with the barbell behind her and kind of tapped her on the upper back slash neck on the way down. But it's not like she had a whole bunch of pain at the time. Later on, a couple days later, went to sleep, woke back up again, and just had this kind of searing, terrible pain down the arm and a lot of pain and stiffness in the neck as well. Although the arm pain was worse than the neck pain. At the time, she went to the emergency room just because it was so scary, right? And not only did she have a lot of pain going down the arm, as well as pain and stiffness in the neck, she actually got a lot weaker. So she literally couldn't bring her arm overhead. And that was the most alarming thing. So obviously, she headed to the emergency room to figure out what was going on. In the emergency room, they just got some x-rays, they ruled out fractures, and then essentially they didn't even really give her a diagnosis. They just said, you need to see a spine specialist. And because she knew me and she knew of us, she felt comfortable going to physical therapy prior to going to see a specialist. So a bit more information about this patient. She's a 28-year-old female. She's a strength coach and a massage therapist, and she's a big fan of weight training in general. She does like the Olympic lifts. She's not a pure Olympic weightlifter, right? So sorry if I kind of bait and switch anyone here, but she does do a lot of Olympic lifts. She also enjoys a little bit of functional training. She likes the Ninja Warrior training and parkour type stuff. Very fit, very strong person. And now I've got a free guide for you today. It's an evidence based cheat sheet to cervical radiculopathy. We go over all the fundamental basics for diagnosis and treatment of cervical radiculopathy. It's an 8-page PDF, and I'll take you from a novice to an expert extremely quickly. I'm going to leave a link in the description so you can go ahead and download that right now and get learning. From the best of her memory, she doesn't recall any sort of history of neck pain or arm pain or anything that would resemble prior history of, let's say, disc pathology in the neck. She basically has a clean slate in terms of neck pain. So, what kind of activities aggravate this at the time? So, basically, it hurt all the time. It was one of those things where she really couldn't get much relief, right? There wasn't a position that felt a whole lot better. Generally speaking, with a lot of these case studies, we talk about, let's say, which movements in the gym end up giving you pain and problems. She was just so irritated and painful. She stopped every activity within the gym. She was having a hard time existing on a day-to-day basis, right? So she couldn't really find any positions of relief. It was just kind of continuous and constant in the neck into the arm. What was actually a little bit nice is she had a relatively fast reduction in pain, right? So the first couple days were absolutely horrible, and then the pain started to go down, down, down over the next several days. And what started with a lot of pain and stiffness in the neck and pain down the arm, most of her symptoms were actually more weakness in the longer term. In the short term, most of the pain went away within the first few weeks. She also reported a bunch of numbness and tingling, some kind of paresthesia, abnormal sensations down the arm, which is a bit of a dead giveaway for cervical radiculopathy, or at least some sort of nerve involvement. In terms of her career, we already talked a little bit about this, but she's a massage therapist as well as a strength coach. And given all the weakness that she had in her arm, as well as all the pain, it was really keeping her from being able to do any of this. And a big problem for her at the moment was, when am I going to be able to get back to performing massage? Because as it stands right now, I can barely move my arm around. It's so painful, it's so weak. How the heck do I get back to this stuff, right? And again, I normally talk about folks getting back to strength training, these case studies, but she had to get back to work, right? She had to get back to her life. That was the first big problem and hurdle to overcome. What's really nice is she's a very disciplined person and she loves strengthening and conditioning. And what's really cool about those folks is that they're willing to do just about whatever it takes to get back in the gym to do the things that they love, right? If I give them 10 exercises, they're going to do all 10 and they're going to ask, hey, should I do this twice a given day, right? That makes it really nice for me as a physical therapist because I know I'm not going to be trying to rack my brain coming up with interventions that are easy to accomplish, picking one or two exercises I think are best simply because I know this patient isn't going to do more than that. I know that she's going to be very disciplined and she's going to be eager to do as much as I tell her to do. So that's really nice from a PT perspective. So, how about her training age? Well, she's been training for a long time and she's been training in a variety of different ways. So, a lot of Olympic weightlifting, but like I said, a lot of parkour, a lot of general knowledge about strength training. She does this professionally, obviously. So, she's really, really good from a weight training perspective. And what's really nice for those folks is that when I start developing, let's say, a home exercise program, I can really rely on them to know the best techniques, right? And the movements they're trying to get back to. So it just helps things out a lot. And it's going to influence the way I write program with these folks. In terms of prior healthcare, so did she go and see a specialist prior to seeing me? No, right? And in a lot of ways, this is a bit of a problem, and I'm getting ahead of myself, but I actually did recommend she go see a spine surgeon just because she had so much weakness. So, what are her goals at this point? Well, she's hurting a lot. Okay. She can hardly move her neck. Neck is killing her. She has this crazy radiating pain down her arm, and she has a ton of weakness, right? So, big thing is she wants to get her pain levels to go down, right? But secondarily, and maybe most important, is she needs to get back to work. She has to be able to support herself, right? She uses her hands for a living, and she does this with massage as well as being a strength coach, right? Now, as a strength coach, you can kind of get away with using one arm and maybe having someone else demo for you for a little bit. But in terms of massage, she needs her strength in order to do her job, and a substantial portion of income is coming from that. It was a big goal for her, right? And then lastly, and this is really isn't in her mind at this point, she would love to get back to higher level strength training, Olympic weightlifting, like I said, some of the parkour stuff. But that's going to be secondary to get out of pain and back to work first. So, what was the objective examination for this patient with cervical radiculopathy? Well, for one, we did a lot of strength testing. Okay. So, in folks that may have cervical radiculopathy, it's nice to do some strength testing because that can rule in cervical radiculopathy if there's going to be some sort of weakness side to side, and also gives us a little bit of information about what level is involved, right? So we went through a full upper extremity manual muscle test procedure. What we found was weakness into external rotation. I gave her a grading of a 3 out of 5 on a 0 to 5 scale, and that's a moderate amount of weakness. Shoulder abduction was actually the weakest movement, and that was a severe weakness. She couldn't even move completely through gravity, and I would say that was about a 2 out of 5. And that is considered severe weakness. And just because she's having severe weakness, if people have moderate to severe, I usually send those patients immediately to a spinal surgeon just to get a second opinion and see if the best case moving forward is some sort of additional treatment that I can't provide, right? She had moderate weakness into internal rotation. I graded that at about a 4 out of 5. And again, moderate weakness in a T position. So laying prone on your belly, arm coming up, horizontal abduction into a T position. I gave that a grading as a 3+ out of 5. How about range of motion? So in the neck, she was definitely limited with range of motion. The biggest limitation was extension. So when I asked her to extend on her own, she was about 75% limited. So very limited there. When I asked her to perform rotation side to side, she was also limited. What's a little interesting here is she was bilaterally symmetrical, right? But about 40% limited on both sides. In some folks with cervical radiculopathy, you'll notice that they're going to be limited towards rotation on the involved side. For her, it was actually both. And the extension checks out as well. So if I extend my neck and I have cervical radiculopathy, that's going to compress the nerve root a little bit more, closes down the intervertebral foramen and creates symptoms, right? And it does make sense that the flexion was not bad, right? I think it was a little bit limited, but not too bad, just because flexing at the neck seems to increase the intervertebral foramen and can reduce symptoms in those folks. In terms of her shoulder range of motion, if I asked her to move her arm fully overhead on her own, she doesn't have the strength to do it. However, if I check her range of motion passively, it's 100% within normal limits, symmetrical, looking good to go. Normally, with my patients, I like to do some sort of regional interdependence, check their squat, check their step down, lunge patterns, all that stuff. I didn't do much of that today just because she had a traumatic injury. So she dropped the barbell on her neck. And is ankle stiffness a relevant cause of that? Maybe. It's just that at this point, I think there's much bigger fish to fry. And then as we start to progress back to Olympic lifts over the course of time, I'm going to start doing more regional interdependent stuff. But this point, I just didn't do it. In terms of movement analysis, the biggest movement that was off, we'll say, is just going to be shoulder abduction. And it's off because she can't even bring her arm fully overhead, right? If I ask her to bring her arm fully overhead on her own, she can get to about, I don't know, let's say 60 or 70 degrees. And if you look at her shoulder blade, she did have a shrug pattern. She also had increased upwards rotation of the scapula. So essentially, she probably had, and we're getting ahead of ourselves a little bit, weakness within the deltoid, and the shoulder is not able to come overhead fully. And because of that, the shoulder blade is trying to help out. So you get the upper trap kicking in, this raises the anterior, and you're going to get upwards rotation of the scapula with elevation, as opposed to pure glenohumeral motion, trying to get that arm overhead. If you guys like what you're learning about so far, then the next logical step is to sign up for the Fitness Pain-Free mini course. I've made an absolutely free mini course, and we go over 4 vital lessons for coaches and clinicians. The first lesson goes over how traditional schooling has failed us. Now, I'm actually a really big fan of education, and I think that physical therapy school actually prepared me pretty well to work with the average person. However, I really didn't learn how to work with the population that I want, which is people in the strength and fitness world. So I'm talking about powerlifting, bodybuilding, Olympic weightlifting, sport of fitness, and really people that just love working hard in the gym. And really, my goal with the mini course is to help you understand how you work with this population to get them out of pain and keep them training. The next lesson is 7 reasons why people get hurt in the gym. So it's vitally important they understand the injury mechanisms or why people get hurt in the gym. If we don't understand why folks are getting hurt in the gym, it's going to be very hard to rehabilitate those folks, because let's say we do get them better, they go right back in the gym and get hurt in the same exact way they hurt before. The other piece is, if we want to keep these folks safe for the long haul, we have to understand the main reason why these folks get hurt in the first place, so we can keep them in the gym training as safe as possible and minimize that risk of future injury. Next, we go over 4 simple steps for getting your clients out of pain. Now, rehab can be very complicated. There's a lot of systems out there that make it very challenging to figure out how to work with your patients. However, it really doesn't have to be that complicated. So I go over 4 easy steps you can follow to get your patients out of pain and back in the gym where they belong. Lesson number 4 is how to build the career of your dreams and earn the respect of your community. Let's face it, the reason why you take these educational courses is obviously so you can learn a little bit more, but really the deep-seated reason is because you want to have the respect of your community. You want your clients to come in, work with you, and say, wow, Joe was great. He did a phenomenal job with me. Tell their friends, and their friends come to see you. And after a while, you're very valued and respected within your community. So I'm going to teach you how to do that. The second piece is that if you know these skills, it doesn't always mean you have a ton of patients going through the door so you can work with the population you want to work with, right? So you may be the absolute best coach in the world, but no one wants to come and see you because they don't know who you are and they don't know how good you actually are. So we'll teach you how to get the patients through the door that you want to work with. And lastly, we'll talk a little bit about the Fitness Pain-Free certification. This is the largest and most comprehensive educational course that I offer, but more on this later. So I'll leave a link in the description, in the show notes. Again, it's 100% free, really easy to download. Go ahead and do that right now. And now back to your learning. So did this patient have any imaging? No, she came directly from the emergency room. The x-ray was negative. But the x-ray doesn't always give us good information about what's happening from a soft tissue perspective. Now, do keep in mind, when folks have cervical radiculopathy, that could be from a herniated disc. That only occurs about 30% of the time. Oftentimes in cervical radiculopathy, you'll have degenerative changes that causing narrowing of the intervertebral foramen. But also keep in mind, this is a young person. It's in a 28-year-old. And people that have severe degeneration, usually this is later on in life. If I had to guess at this point, I would reckon she had some sort of disc pathology creating this issue right here. But again, we didn't have the MRI imaging in order to figure that out. How about palpation? So initially, this patient was pretty tender in a variety of places. The areas that were most tender were in the scalene, so right on the side of the neck, as well as the upper trapezius and levator scapulae. We actually got more tenderness over the course of time in the upper trapezius and levator scapulae. And again, that was probably just because those muscles are trying to compensate for other weaknesses at the shoulder. But initially, she had a lot of tenderness there, as well as in the side of the neck. Most of her pain was also in the side of the neck and in the shoulder blade and shoulder region, which, thinking about it now, probably does match up with the type of nerve root injury that we think she has. In terms of sensation testing, it was more or less about the same side to side, but if you did touch the side of her shoulder down to the elbow, she did have diminished sensation. It just felt a little different side to side. In terms of special tests that we performed, because what we're trying to do is try to rule in issues at, let's say, the neck over the shoulder, right? And we did a few tests in order to figure that out. So the upper limb neural tension test was positive. She also had a positive distraction test as well as a positive Sperling test. So when we did these tests, it reproduced that numbness, tingling, kind of burning, shooting pain down the arm. In terms of red flag testing, I didn't see any, which is good. At this point, it means we can proceed with physical therapy treatment. The only red flag that we did find with this patient is that she failed to subscribe to the Fitness Pain Free channel as well as like this video. And I want to make sure that you actually like this video, or you may end up with a cervical myelopathy. Not good stuff. We also did some reflex testing with this patient. There was a diminished reflex at the C6 level. This would be the biceps reflex. Now, given the weakness that we found where the patient was feeling her pain, so think about in the neck, in the shoulder blade region, where she was having diminished sensation. So, again, in that same area, weakness of shoulder abduction, right? A little bit of a deficit in terms of biceps flexion strength. I diagnosed her with a cervical radiculopathy at the C5, C6 level. All right, so we came up with this diagnosis. What are the next steps? What is the decision making? Do we need to send back to a doctor? Do we start treatment right away? What are we doing at this point? So, the first thing that I recommended was that she probably goes back and sees a physician. And the reason being is that she has severe weakness, right? She can't even bring her arm fully overhead. Okay. Now, the literature in lumbar spine radiculopathy is pretty clear that if you have a radiculopathy with moderate to severe weakness, then you probably want to undergo some sort of emergency surgery early on within the first, let's say, 48 hours in order to have the best long term outcome from a strength perspective, right? Now, there isn't robust literature to show the same in the cervical spine, right? So just because we don't have the literature doesn't mean it doesn't exist. At least for me, if I see someone that has moderate to severe weakness, I'm sending back to the doctor right away. The only problem is she's already a week out, right? And if she was going to get some sort of emergency surgery, she would have done it right after the injury, which brings us to this point of people probably need to be triaged a little bit better in the emergency room. So if the emergency room docs know that when folks have severe weakness, especially in the lumbar spine, but also in the cervical spine, they probably need a spinal ortho consult right away to determine whether or not they get surgery. Because what ends up happening is that we see them a few weeks later. At that point, they're not going to be a good candidate for emergency surgery anymore. And they may end up with longer term issues because we didn't make the right decision from the get go. Spoiler alert, she never ended up going to a surgeon. So to this day, we didn't get an MRI. We're not exactly sure what was going on within the neck, but based on the clinical examination, I think we can be relatively certain of what was going on. The next really important step is to monitor for progressive symptoms. So basically, if the patient comes in week one and they've got a bunch of weakness, okay, and they come in for their second visit a week later and they're actually weaker, that's a bad sign. And that means you have to go to the surgeon immediately, right? What's at least a little bit nice if someone has moderate to severe weakness, if you tell them to go to the doctor right away and they are progressing, by the time they get to the doctor, hopefully they can pick up on this and then they may make a decision to do surgery right away because you're having progressive symptoms. It's obviously a bad thing. And that is a red flag, which may require emergency surgery. Now, with all of that out of the way, we can just start our physical therapy treatment. So, what was the plan of care in this patient with cervical radiculopathy? Well, step one is going to be educating the patient, right? So, first and foremost, we want to give them a good diagnosis. The thing about cervical radiculopathy is it's very odd, right? So, folks have pain and stiffness within the neck, and then they also have a lot of pain going down the arm, right? Not only that, but this pain is shooting, it's severe, doesn't feel good, obviously. People have abnormal sensation. And probably the oddest thing is that they have a lot of weakness going on, right? Now, if a physician doesn't educate the patient on what's going on, they can start to brainstorm or try to figure out what's going on their own. And sometimes it ends up being really bad. Go through Dr. Google, right? Dr. Google tells them they might need neck surgery or something along those lines. They may talk to their Uncle Larry, who's had neck pain for years, for disc injuries. And all of a sudden they feel hopeless, very scared. They don't move whatsoever. They start thinking that this issue is a lot more severe than it actually is, right? And that's a bad thing. So the first thing we want to do is give a lot of good information to the patient. We have to be a little cautious not to scare them, right? So like I said, I had diagnosed her with cervical radiculopathy at the C5, C6 nerve root, right? One of those two is my best guess. And what's probably going on is she may have had a herniated disc. It's a little odd that she didn't have pain when she dropped the barbell on her neck and it happened 2 days later, but maybe there was something going on with the initial injury and then a couple of days later it worsened, right? I'm guessing that she probably did have a non-contained disc herniation, so essentially the inside of the disc leaking outside. And my guess for that is that her pain was just so severe, probably from the inflammatory reaction that occurs from the nucleus pulposus coming out and leaking out onto the nerve. And again, this is my best guess. We don't have an MRI to confirm this. Once I get this scary stuff out of the way, it's just really important that we educate folks about the positive prognosis of these injuries. And the big thing to let your patients know is that they are not in threat of any sort of life altering, life threatening injury at the time, right? The large majority of cervical radiculopathy cases actually get better over the course of time. The weakness that you're having right now obviously is not great, but it does improve in the majority of people over the course of time. And the last piece I think is important to educate patients about, and this stinks to hear, but it is true. So I don't want to lie to my patients. Oftentimes it takes multiple years for this to improve. And largely, a lot of your initial symptoms, so a ton of that pain and stiffness, that'll go away relatively quickly, let's say within like weeks to months. However, some of that weakness can linger on for years, unfortunately. So I really think patients need to know that so they can be diligent about trying to regain that strength over the course of time. Our second plan of action is to try to calm the area down as best we can. If we can decrease some of these symptoms, it's going to make the patient feel a whole heck of a lot better and push them into a positive way. So, the big things that we talked about initially are trying to avoid prolonged postures. So, at this point, when the patient was sitting for a long period of time or standing for a long period of time, let's say that we were reading something or reading a computer screen, they really noticed their neck got really painful and really sore. So we just recommended to do some constant frequent motion. And I'll show you the exercise we use in a minute, all throughout the course of the day. So they don't get to the point where they're really, really painful. I often educate my patients to just let them know when they're in a lot of pain, it's actually hard to get out of pain. But if you can keep yourself from getting into more pain, that's usually a much better decision and way to manage your symptoms over the course of time. We also avoided reaching into extreme ranges of motion. So think about the positive upper limb neural tension test. And it was actually very positive when we first started. What that means is if this patient tries to reach down or up or extends the arm out and stretches those nerves, that might be provocative as well. So I use a magic box analogy. I got this from one of my professors, Professor Butler, back in PT school. Essentially, pretend like you have a small box in front of you, right? When you do any work that's in front of you, you don't want to reach outside of that box. That means you'll want to reach to your side or behind your body or over your head. Keep all of your work right in front of you inside of this magic box. And of course, this is not what you have to do for the rest of your life. But early on, if we keep flaring this thing up, it's just going to make the patient feel miserable on a regular basis. And obviously, that's not what we want. Like I said, I'm a big proponent of frequent, easy movement early on after this type of injury. One of the problems after cervical radiculopathy is that the pain is so severe and the weakness can be so severe that patients get really, really scared of moving. If you can educate them that moving is very, very important in the healing of this condition, then they're more likely to do it. And the other piece is you got to show them the movements to actually do so they can improve themselves. And lastly, in terms of training, so this patient already stopped all forms of training. And obviously, she was so painful. She wanted to see me before she started anything. But I want to get this person back to doing any form of exercise they can at this point that doesn't aggravate the neck too much, because I really believe that's going to help to prevent deconditioning. But if we can continue with aerobic exercise, a little bit of weight training, our literature shows that's actually beneficial for getting out of pain for rehabbing. So we want to try to push this as much as possible. And I'll tell you how we did this in a bit. So, in a nutshell, we wanted to provide a well rounded program for her neck and arm, right? What did that consist of? We gave her neck range of motion exercises. We gave neck endurance exercises. We also worked on neck strengthening exercises. We gave isotonics. We also gave isometrics. Like I said, more endurance based exercises. We gave exercises for the deep neck flexors. We also focused on scapular strength and stability, as well as providing nerve glides and stretches. The next important piece of the puzzle is that we emphasized strengthening the weak areas. Now, if you look at the research about treating cervical radiculopathy, I didn't really see much in terms of trying to strengthen the weaker areas as a beneficial treatment for these folks, but it makes a lot of sense. If they're going to be weak, let's say in the deltoid, like in this case, if we don't treat the deltoid directly, are we actually going to be able to get the strength back over the course of time, right? So I try to include a lot of strengthening for the specific area that's limited. Next, we have a slow progression back to training over the course of time. She's probably not doing a lot of bench press right now just because she has no deltoid strength. But as she starts to regain that strength, we want to slowly progress back to that. And lastly, and this is really important, we want to monitor her strength over the course of time. So, visit number one, we took a look at her strength, right? Visit number two, we look at the strength again. And if we're noticing that the strength is going down, if the patient is weaker, that's an emergency situation. They need to be referred to the doctor right away. So, what was my recommended frequency of visits at the start, right? So, I'm in a cash based setting. It's a little bit more expensive than the average PT place. I tend to see people a little less frequently than most other physical therapy facilities. And in my mind, I think we can get the majority of treatments out of the way on a weekly basis. So, basically, just seeing that patient once per week. Now, I think you can also make the argument for seeing these patients twice a week because in a lot of the medical literature, what you'll find is that patients go to physical therapy 2 to 3 days per week, and then they do a home exercise program on their own. And if you're going to be using, let's say, manual therapies to treat these patients, in most of these studies, they're getting manual therapies twice a week for the first, let's say, 4 to 6 weeks, right? So for me, I felt that I can get the majority of what I wanted with this patient in 1 day per week, but I obviously think you can make the argument for 2 days as well. I also let the patient know that I think we can do physical therapy for around 4 to 6 weeks. And at that point, we can have intermittent visits to see how she's doing, update her program. But the first 4 to 6 weeks are probably going to be most important. And generally speaking, I usually tell my patients what I think is going to be best for them at the outset of physical therapy. And then I also ask a lot of questions about what's reasonable for them, right? If I think what's best for them is going to be 3 days per week and they can only do once per week, we got to try to meet in the middle somehow. And lastly, with this patient, we really didn't even end up seeing her once a week. It was more like once every week and a half to 2 weeks, right? And a lot of that was because she just had a busy schedule. And the other part is that we didn't end up seeing her, continuously for 4 to 6 weeks and then intermittently afterwards. Life got in the way, all that stuff. But you'll see how this kind of unraveled in the rest of the presentation. I also plan to perform a bunch of manual therapies with this patient. Largely, if you add manual therapies to your exercise treatment plan, that will enhance your outcomes in the short term. So, somewhere between right after the application of the manual therapy up until about 4 weeks or so. Do you need manual therapies to get your patient better? No, not necessarily. But if you have a patient that's very, very painful and wants some relief, this might be something that's really good to help them. In my mind, manual therapies are a lot like medication. So, if you have a headache, right, you want it to go away, could you just wait for the rest of the day and then sleep at nighttime and wake up and have the headache feel a little bit better? Yeah, probably. Sometimes it'll take a couple days, but it's almost certainly going to go away in time, right? Now, if you want it to go away in 15 or 20 minutes, you can take ibuprofen, right? So what are you going to do? You're going to take the pill, pain goes away right away, or you're going to wait a couple days. And that's a decision to be made by you or the patient. So if the patient wants immediate relief, then definitely, if you have the means to do that, I recommend trying to do it. Just that you shouldn't be selling manual therapies to your patient and say, like, the only way you're going to get better is if you get these manual therapies. Okay. That's also important to tell your patient. So, what specific manual therapies did we use? So, we used a variety of nerve glides with and without distraction of the neck. We also focused on mobilizations, lateral glides, rotation mobilizations, thoracic manipulations. We also did some central and unilateral PAs, some of those classic cervical spine techniques from Maitland. And lastly, we did incorporate some soft tissue mobility work to the upper trap and levator scapulae. Early on, this was very painful, but it also maintained its soreness just because that area was compensating so hard for a lack of deltoid strength that it got pretty irritated over the course of time. And doing some manual therapy treatments was really helpful for the patient. She's also a massage therapist, so she believes in this, right? So if she believes in it, I believe in it. That's going to enhance the outcomes for her. And she actually felt quite a bit better after those strategies. Hey guys, if you are getting value from this video right now, please hit that like button. If you want more great content from me in the future, please subscribe to the channel. Helps me out tremendously. So what do we do in terms of activity modification for training in the gym? Now, I didn't even give her a gym routine on the first visit. That was actually a few visits in the future. But I do think it's important to talk about what's maybe okay to do and what's not okay to do within the gym. Now, I often give patients the information from the pain monitoring system. Essentially, if you perform the movement, if it feels tolerable, it's less than a 5 out of 10 on our 0 to 10 scale. After the exercise, you feel like you're back to baseline, and the following day, you're back to your baseline, then it's A-OK to work through a little bit of pain. Like I said, our goal is continue exercising. And this is true across the board for every single patient that I work with. There are a myriad of benefits from exercising. And getting an injury like this is going to be a major reason why a lot of folks stop exercising, become less healthy, and that's no bueno. So, we're going to try to push exercise as much as we can for two reasons. One, keeps you healthy, right? And that's no brainer. Two, if you do it right, these modifications and continuing to train actually will reduce your symptoms. So, again, if you're thinking about cervical radiculopathy treatments, we know aerobic exercise as well as resistance training can help to reduce patients' pain. So, if I can keep people in the gym, I'm going to do it as best as I can. It's just that if you have a really aggravated the neck and doing a whole bunch of behind the neck presses, behind the neck pull downs, probably not going to feel phenomenal in the beginning. Over the course of time, we can progress back to those movements that used to be really challenging on the neck. So, in terms of things that we chose to modify in the gym, the big one was end range reaching. So, if you think about a pull up, in the bottom of a pull up, you are really stretching all the nerves from your brain to your fingertips. So, early on, we did more partial range of motion pulling. We did more, let's say, horizontal pulling like TRX rows, and then eventually worked our way back to pull downs and then pull ups. The other thing that we really had to modify a lot for a long period of time was basically overhead pressing. So we just talked about how our patient has so much weakness in the deltoid. If I try to give her an overhead press, there's no way she can give her arm overhead. She's not going to be pressing anything, right? But we were able to get away with a few horizontal press variations, light. And over the course of time, we just increased the incline. So we started flat, worked our way on an incline. Maybe we incorporated some landmine press, and eventually she could press overhead. Just took a long time to get that back. And what was at least nice is that this patient maintained a lot of strength in rowing. Okay. When I gave her pressing exercise or abduction exercise, initially I had to give her assisted range of motion just because it was so weak. She couldn't even fight against gravity. Right. However, she still could get away with rowing exercises and load them up. So we made an exercise program that was just heavy with a lot of rowing. And we did want to make sure that we we're strengthening abduction and pressing. It's just we had to modify that much more heavily. So day one, patient comes in, we go through the entire evaluation, plan of care, so on and so forth. What are the exercises that I give to the patient as a home exercise program? So initially, my recommendation was to perform all of these motions 1 to 2 times a day. The other piece, like I said, is that nerves do like constant, frequent motion. Usually, it makes patients feel better. So if these movements feel really good, you don't have to limit them to 1 to 2 times a day. You can do these as much as up to every single hour if they feel really good. So largely, I'll tell my patients, try to get them done once a day. If it feels really good, you can do it 2 or 3 times. And you can also pick a couple of the exercises that feel the best and just do them every hour or so, right? Not mandatory to do this, but if patients are in a lot of pain and movement helps them, then yeah, I say this is a great recommendation. So initially we started with some nerve glides, mostly of the median nerve. And the glides we chose were nerve glides without neck motion, just because the neck was pretty dang aggravated. We also had to make sure that we weren't pushing through too many of those weak spots, right? If you think about upper limb neural tension tests, glides in that position requires shoulder abduction. She doesn't really have that movement quite yet. So we had to be a little bit smart and use our brain to give some good glides that allowed her to perform the movement, right? Because she has so much weakness. And it wasn't too irritating just because she has so much positive neural tension and has limited mobility in that nerve. In terms of cervical range of motion exercises, I typically give folks range of motion into every direction. Okay. And this is basically because if you give range of motion exercise to your patient only in one direction, so the idea is if I have cervical radiculopathy on, let's say, my left side, right, left shoulder is weak, if I rotate away from that side, if I flex my neck some, and if I side bend away from that area, all those motions are going to increase intervertebral foramen. And hopefully that will help to reduce people's symptoms. It's just that if you compare exercise programs that mobilize into every direction versus into the direction that opens the intervertebral foramen, the outcome is the same. So largely what I do is I tell my patients just to push into the directions that feel good. And over the course of time, as your range of motion improves, and you just push into all of the motions equally, right? So we're talking about rotation side to side, cervical flexion and extension, and lateral bending side to side. And lastly, the basis of our strengthening program was basically a supine chin tuck with a towel behind the neck. And when you chin tuck, trying to push your neck into that towel. Okay. So, not really challenging exercises from the beginning, but we're just getting started. And the other piece is I often try to do a little less at the start of physical therapy, just because if the neck gets irritated by somewhere between the first and second visit, and we gave 1,000 exercises, we're not really sure which exercise caused the problem. So we start with very easy exercises, not too many of them. And over the course of time, as patients start to make progress, we just push more and more, but slowly. I also recommended my patient perform some scap squeezes, 2 sets of 10 to 15 per day, another evidence based treatment. I also recommended some walking. I think this is beneficial for a variety of reasons. So, one, you had a major injury and your body is used to moving all the time. And she's an athlete. Her sense of self is completely wrapped up in being able to exercise. So, I want to allow her to exercise a little bit, right? So the walking is going to be very beneficial because the walking is probably going to help glide that nerve, speed up her recovery, but it's also going to make her feel a little bit like she can exercise some. And that's going to be really important because an injury like this will really sideline an athlete, right? And really is a major strike on their sense of self. And it's kind of an identity crisis. So as much as we can keep them moving, we want to try to, right? And lastly, I ended up giving a lot of assisted range of motion exercises, right? So think about the same exercise you would give to a post op rotator cuff repair, where you have a cane and you have two arms on the pulley, or excuse me, two arms on the PVC, and you're lifting straight into flexion and you're using the opposite arm to assist. She had a 2 out of 5 strength. She can't move completely through gravity. So utilizing the other hand on a PVC to help out allows her to work that side a little bit, right? Without causing major compensation. We want to regain that deltoid use. We're going to try to do that as best we can, as much as we can. So we wrap up the first initial evaluation. The patient goes away. They come back in 1 week. What's the second visit like? So the first thing is I ask questions about how things are going, right? What's really cool is that she had dramatically increased her range of motion within her neck, right? Her pain and symptoms had dramatically lessened, which is phenomenal, right? And she also had an improvement in her strength. So she could actually move through a full range of motion. It didn't look great, but she can get all the way overhead with some compensation at this point and a lot of concentration, right? And that's a great thing because what we found is that her strength actually improved from visit 1 to visit 2. We don't have an emergency situation anymore. I don't feel like she has to get to the doctor right away, right? I still recommend she goes and sees the doc, but I'm not going because I think there's an emergency situation. So after we get a little gauge on how she's progressing, the first thing I focus on are the manual therapies. And like I said, we focused on some upper trapezius and levator scapulae, soft tissue work. I like to use some tools, some cupping. I also like some needling. We worked on some cervical lateral glides. We did some distraction mobilizations. We did some nerve glides. We did some prone thoracic manipulation work, as well as some prone cervical PAs and some prone cervical unilateral PAs. In terms of the exercises that we gave to the patient this session, we continued all of the daily exercises that she did on her initial evaluation. So those movements didn't change. However, I really wanted to get her on a more robust strengthening programs. So essentially, we got her on a 2-day program, 3 exercises each day, right? We focused on general upper body strength training. We focused on strengthening for the neck, focused on strength of the scapular exercises, and we put extra emphasis on those weak areas. Okay. So, day 1, the 3 exercises we had were dumbbell press to a prop. So, think about doing a Turkish get up, right? But not going through the full range of motion. Second exercise was a plank position where you perform a T. So, great scapular stability on one side with a T. So great scapular stability exercise where you're planking on one arm while the other arm raises up into a T position. And lastly, isometric band step outs. We did these in all directions. So essentially you have a band around your head attached to a rig or something stable, and you step out to the side and you get an isometric contraction for whichever direction you're facing. So we did it with the band facing to the side. So you do some scaling strength, and then you move the band to another position where maybe you're facing the band. Now you're working the cervical extensors. If we flip and face the opposite direction and step out, now it's going to be working the front side of the neck. Day 2, I prescribed a dumbbell scaption. Couldn't use very much weight, but just a little bit, right? Want to start to strengthen that deltoid a little bit. We also gave a reverse crawl, so on hands and knees in kind of a bear position and taking steps backwards, working on protraction, great scapular stability exercise, so the core work. And if you think about the neck position, we're also working on the deep neck extensor endurance. And again, the same band step outs on day 2. Another thing I'm big on in my patients with cervical radiculopathy is trying to get some good objective measurements, right? What's a little bit scary and not great is that the majority of folks, when they're doing a neuro examination, they're just testing your strength, right, with your hands. Okay. To me, this is akin to, let's say you're trying to weigh someone, right? And as opposed to putting them on a scale, you try to pick them up. You're like, oh, that's 150 pounds. Well, we're not great at basically figuring out how much someone weighs by picking them up, right? We're also not great at figuring out how much strength someone has just by feeling their resistance, right? How much they can push against us. So it's really good to use a handheld dynamometer to get some real numbers, some accurate numbers, so you can gauge your progress over the course of time. And that helps you direct the exercise you give to your patients, right? So we use the handheld dynamometer to see just how weak she was from side to side. And we tested external rotation, abduction, as well as pro and T, just because those are the movements that were mostly involved. There was a little bit of weakness in internal rotation, elbow flexion, but it wasn't too bad. And it was actually improving pretty rapidly. So I wasn't as concerned about getting a good measurement on that. And what we found is that there was a 76% asymmetry in abduction, which actually pretty huge, right? So she only has, let's say, 25% of the strength on the involved side compared to the uninvolved side. And the same thing went for the prone T. So she had a 72.5% asymmetry, so huge asymmetry. And then from an external rotation perspective, it was 47% asymmetry. So about half the strength left to right. Obviously, that's still not good, but the big heavy hitters, the ones we really want to focus on, probably going to be the deltoid and maybe the posterior deltoid and some of those scapular muscles, because right now they're pretty dang weak. And just know that it's really, really important to make sure that you test finger strength. Just because if you don't have finger strength, there's no way you're going to be able to like this video and subscribe to the channel, which I highly, highly recommend. So, in future visits, how do we advance her home exercise program? So, for one, we just made it more robust. So, we added more exercises and I gave her a third day. If you think about folks like that train in the gym, they usually have multiple days they train throughout the course of the week. They don't do the same exact thing on each day. So, my goal is to give them a program that very closely resembles what they already do. I think this is good for a variety of reasons. So, for one, we're actually doing what they like to do. So they're going to be much more likely to do this, right? If I give them exercise they currently enjoy, they're much more likely to be compliant. The other piece is I don't want to add anything additional to their schedule, right? Because if I start asking them to perform additional lifts in the evening, in the morning, it's really hard to change your habits on a regular basis. So if I can have the program closely resemble what the patient is already doing, just put those exercises directly into the current training program, I think that's a big win-win. So on day one, we added in some plank position shoulder taps as well as some face pulls. On day two, we added in some different variations of face pulls as well as some bent over rear delt flies with dumbbells. On day three, we threw in some dumbbell lateral raises. So, as you can see with this strength training program, we want it to start looking like an actual training program. That's important. But the other piece is we're starting to really target those weak areas. I know that deltoid is weak. I want to get that thing stronger. I'm going to overemphasize strengthening that. And largely, this program was performed 3 days per week. So you have a day one, a day two, and a day three. You perform this on a Monday, Wednesday, Friday. And on the off days, we can still do those daily home exercise program exercises that we got at the initial evaluation. So, next, let's actually go over what a physical therapy treatment session looks like, right? So, I recommended 30-minute sessions for this patient. One of the reasons why we recommended 30-minute sessions were an hour is just going to be a little bit more expensive, right? Currently, she wasn't working, so she wasn't making a lot of income. So we made those sessions a little bit shorter for her. The other piece is that she's a smart strength coach and trainer. I don't think that I need to watch her do all of her exercises. I actually think that's a little bit of a waste of her time and mine. So if I write her the right exercises, make sure she does them right in the clinic, I'm pretty confident that she's going to do them at home. Okay. Hence, a shorter session is probably okay with this patient. So when the patient first walks in, I like to check in with them. How are things going? Have you made progress from last week? Are you having additional pain? Right? Checking in, see how things are going. I also like to ask questions about whether or not the patient feels like they're moving in the right direction. Basically, this is a question to ask more about the patient's needs and whether or not we're satisfying those, right? Because oftentimes, as a physical therapist, you might think you're doing a bang up job, but the patient maybe doesn't believe that. So it's important that we understand what's going on within the patient's mind so we can really meet those needs. And lastly, I try to ask this with most of my patients at the start of each session. What are your goals for the day? Is there anything you really want to focus on? This is helpful because it helps to guide what we do for the day, right? It's also important that I let the patient know what I plan on doing because oftentimes you come in, you expect to do one thing with the patient, but they're like, hey, I really want you to look at, let's say, my elbow or my neck, and that's really bothering me. Or I really like that manual technique where you did X because that helped me out a ton. So it kind of helps direct the treatment. And I think it's beneficial for the patient because it helps to establish a little bit more rapport via empathy. Next, I do a quick assessment. Let's check out that abduction. Maybe I'll strength test a little bit, see if that strength is coming back. Check the range of motion at the neck. How's that rotation feeling? How's extension? So get an idea of what's still limited and what we have to continue working on. Helps direct my treatment with the patient over the course of the session in the future. You can also check some of the special tests. One good special test to maybe check is the upper limb neural tension test. Are we making progress here? We can check the range of motion, and given how irritated that nerve is, maybe we give more advanced nerve stretch exercises if they're progressing from that perspective. And after our check in and our assessment, I go right into manual therapy treatments. So the initial check in is going to take about 2 to 3 minutes, the assessment, another 2 to 3 minutes. And then I spend around 15 minutes or so with manual therapies. Obviously, this is going to change based on the person, based on how many therapies you want to get through. But at least for me, that's about how long I spend. I start off with some soft tissue mobilizations. Usually, I do some cupping, I do some needling, I do some tool work, I use my hands a little bit. From there, I move on to joint mobilizations. So we flip onto the patient's back. We're doing some cervical lateral glides. We're focused on some rotation glides. From here, we'll do some nerve glides. We'll do some nerve glides with some distraction. We can flip from this position and focus on some thoracic mobility, so a thoracic spine thrust manipulation. And then we can do some central PAs in the neck as well as some unilateral PAs. After we finish up with manual therapies, we got another 10 minutes left or so. And at this point, we go over any new exercise. So basically, if I think we're ready to advance, we'll go out in the gym, we'll try those movements, I'll coach them up, make sure the technique is good, make sure the exercises are appropriate. And with the last little bit of time that we have, we sit down, we type it up into the home exercise program. I use Google Docs for all of my home exercise programs. Make sure the patient is on board, ask them if they have any questions, maybe outline the next steps from a physical therapy perspective, and then send them on their way. So our initial plan was to see this patient once a week for 4 to 6 weeks. And then at that point, do intermittent visits every month or two to gauge her progress and just update her plan, right? So this often sounds great on paper and then in reality doesn't always work out. So essentially, she had more intermittent visits. I actually only saw her for a total of 5 visits. The first 4 visits were over the span of about 2 months. She was busy. She had a lot of stuff going on. She had some traveling to do. And after that fourth visit, she was supposed to come in a couple weeks and she just didn't. And I get it. Life gets busy and she was feeling better. I'm okay with that, right? I actually didn't end up seeing her again until almost the year mark. So, best laid plans don't always go perfectly. But at the end of the day, I think we actually did a pretty good job helping her. And if a patient doesn't follow the plan exactly, I'm okay with that. It's their decision, right? I'm here to serve them and guide them. If they feel like they got what they needed out of me and they can do this work on their own, then awesome. I've done my job. So I'm trying to teach them how to take care of themselves, shift that locus of control, right? So again, we had 5 total visits. The majority of the visits were 30-minute sessions with an hour initial evaluation. I think our last visit was kind of a reevaluation because I saw her a year later. What we ended up doing was just checking out her strength and then giving her new exercise to focus on. And her strength really did improve quite a bit. In terms of external rotation, she was nearly symmetrical. So just a couple pounds of force off left to right. In terms of abduction strength, she was still a decent amount limited. So on her uninvolved side, she had 30 pounds of force produced. And on her involved side, she had 26 pounds produced, right? So around a 4 pound difference. So a decent amount different side to side in abduction, but substantially better, right? She had a 75% asymmetry when she started. This is around a 5 to 10% asymmetry, right? Way, way better. In terms of her T strength, that was also still limited. So she was at a 9.4 on her involved side and a 12.2 on the uninvolved side. So about 3 pounds, 2 to 3 pounds off strength wise and still limited. So, at least in my mind, what this means to me is that A, It takes a long time to get your strength back after cervical radiculopathy. I tell you what, this is one of the most disciplined patients you're ever going to work with, right? So if these super disciplined patients at the year mark are still dealing with substantial differences side to side, right? Then those people that don't like to exercise, good chance they're going to be even weaker at that year mark. So, like I said, this patient is a strength coach, right? So, I don't need to write a very specific strength training program for her. She already can do that. So, as opposed to giving her a super specific strength program, I just give her recommendations in a template format, right? So, generally speaking, I said once a week, you should be doing some sort of single arm pulling, right? So, it might be a dumbbell row or single arm pull down. Now, we just said that rowing was a little bit better off than pressing. So my recommendation was to put a little bit more focus on pressing than pulling. And I gave her a variety of movements that would fit the bill. So things like landmine press, dumbbell overhead press, or steep incline press, or some sort of single arm press laying flat, like a cable press or a dumbbell press. Cable press, you would be standing like a punch press, right? But a couple exercises where you're pressing overhead, and maybe one exercise where you're pressing horizontally. I also recommended 2 to 3 times per week, full can shoulder abduction. Like I said, good old abduction was most limited at the start. It's most limited now. Let's keep on working on it. We reevaluated her nerve mobility. And at this point, she was actually most limited in the ulnar nerve. So I ended up giving her an ulnar nerve stretch and glide. I also gave her a more intense median nerve stretch because she was still a little bit limited, but not too bad. So I gave her something that was a little bit more aggressive, something you wouldn't give your patient at their initial evaluation, right? In terms of her cervical range of motion, it looked great. She had no problems there, right? So keep in mind, she was extremely limited in the beginning, right? And at the year mark, no limitation whatsoever in range of motion, no limitation from a pain perspective, sensation, all that stuff has returned. The only thing that didn't was her strength. So a program should obviously reflect that. So now you know how I like to treat my patients with cervical radiculopathy. You still need to know some basics about cervical radiculopathy. What am I talking about? You need to know how to diagnose your patients. You want to know things about, let's say, prevalence, anatomy. What are the best treatments for cervical radiculopathy? Should you be doing exercise, manual therapies? Should your patients consider things like injections or surgeries? When should you recommend things like injections or surgery with your patients? What are medical red flags? All of that good stuff. I have a complete guide. It's a masterclass for cervical radiculopathy. I'm going to leave a link in the corner. Definitely go check that out, and I will see you in that video. And lastly, thank you so much for joining me today with this lesson on cervical radiculopathy. You truly allowed me to do what I love for a living. I love educating. I love learning about this stuff. I love sharing. And I wouldn't be able to do it without folks like yourself. So thank you. If you're watching this on YouTube, please hit that like button. Consider subscribing to the channel if you enjoy this. If you're listening to the podcast version of this, please give me a 5 out of 5 rating. It helps tremendously. And lastly, if you want to go that next step and support me further, consider subscribing to Fitness Pain Free Insiders. So, Insiders is like Netflix for physical therapists and coaches working with painful folks in the gym. You've got access to 100 plus webinars, ebooks, and courses. More recently, I've been taking all of my best content from YouTube. I've been taking out all the ads. I've been organizing it in a really step-by-step fashion in an entire course so you can easily go through it. And I add additional pieces to this to enhance your learning, right? So I just finished up my lateral ankle sprain course. And one of the big things I add to this was a protocol. So essentially, what do you do week 1, week 2, week 3, week 4, week 5, 6, 7, 8? You know me, I like working with athletes. I like working with really fit and strong people. So it's going to be a lot more robust than your typical protocol. Also, you have access to me. So inside of Insiders, you can leave a comment and I'll get right back to you. I also have physical therapy CEUs inside of Insiders. So if you take the course Essential Coaches Series, get a bunch of CEUs. And what's even better is you can start for just $1. After that, it's $25 per month. It's going to be the cheapest CEUs you can get. It's by far the highest value program that I offer at the cheapest price. So head over to fitnesspainfree.com, click on the program's link, and then click on Fitness Pain Free Insiders to get started. I'll also leave a link in the show notes where you can check it out.